Hi everyone, welcome back to my YouTube channel. We are going to talk about subdural hemorrhage. As you can see here in the diagram, showing different intracranial hemorrhages, there also subdural hemorrhages is present in this diagram. So let's start our topic with introduction. Subdural hemorrhage is a bleeding that occurs between dura mater and arachnoid mater. It is usually caused by tearing of bridging veins that cross this space, often due to trauma that suddenly jolts the head. The resulting blood accumulation can be acute, subacute, or chronic depending on how quickly it develops. Talking about its types, it includes acute subdural hemorrhage that develops within the 72 hours after a severe head injury. It is often associated with high speed trauma or significant brain injury. It can cause rapid neurological deterioration. Next is subacute subdural hemorrhage. It develops over 3 to 21 days. Its symptoms may be subtle and gradually progressive. Next is chronic subdural hematoma. It occurs over a week to months. It is more common in elderly alcoholics and individuals on anticoagulants. It often results of minor unrecognized head trauma. Now let's talk about causes and risk factors for subdural hemorrhage. It includes head trauma that is even minor in older adults is enough for cause the subdural hemorrhage. Brain atrophy, especially in the elderly, which touches bridging vein and thus can cause rupture of these bridging veins. Next is anticoagulants or antiplatelet medications can also be the risk factors for subdural hemorrhage. Alcohol use and coagulopathies are also the risk factors. Coagulopathies are blood clotting disorders. Now let's talk about clinical presentation of subdural hemorrhage. Symptoms may vary from severity and speed of onset. They include headache, altered mental status that may include confusion, drowsiness, and irritability, focal neurological deficit that include weakness and speech difficulty, seizures, unilateral pupil dilation that is a sign of increased intracranial pressure. In chronic cases, forgetfulness, gait disturbance, and lethargy mimicking dementia. Now let's talk about diagnosis of this lecture video. Non-contrast CT scan is the gold standard for diagnosis of subdural hemorrhage. In acute subdural hemorrhage appears as a crescent-shaped hyperdense area, and chronic subdural hemorrhage may appear hypodense or isodense depending on the blood age. MRI may be helpful in subacute or chronic stages or when CT findings are unclear. Treatment of subdural hemorrhage is by conservative management. First we do that is when small asymptomatic bleeding is there and they be monitored with serial imaging. Second, we do can do a surgical intervention. It is burr hole drainage or craniotomy to relieve pressure in large asymptomatic subdural hemorrhage. It is used if there is significant midline shift, herniation signs, or declining consciousness. Third, we do is supportive care. It is managing intracranial pressure, reversing anticoagulation if present, and seizure prophylaxis in some cases. Now let's talk about prognosis of subdural hemorrhage. Prognosis depends on age, volume of bleeding, timing of diagnosis, and underlying brain condition. In chronic subdural hemorrhage has a good prognosis if treated promptly. Acute subdural hemorrhage with extensive mass effect can be life-threatening if not addressed quickly. Now let's talk about conclusion of this lecture video. Subdural hemorrhage may be simmer silently or strike suddenly. Their crescent-shaped signature on imaging conceals complex dynamics of bleeding, swelling, and cerebral compression. Understanding their timing, cause, and warning signs can be difference between a life and lasting injury. And this was all about subdural hemorrhage. Hopefully you liked the video. If you do, don't forget to like, share, subscribe, and comment. Thank you for watching.